Okay, so I want to show you a couple of things. We have just basic vertebral augmentation kit. I've got this needle. It's a beveled needle, so it's beveled just like a spine needle that I showed earlier was. Then you have a diamond tip, and this is tri-bevel. And so typically people may access with the diamond tip, then follow it up with the single bevel to be able to penetrate this. It's probably not possible to see on this distal tip, but notice that it's got kind of an arrowhead shape on that. So this is very good. It's not only beveled, but it's got additional secondary bevels on it. So this is good for hard bone. So with that, I'm going to show you a couple of trajectories and approaches. I'll show you just para and transpedicular. So picture. So transpedicular is centimeter up, 2 centimeters out. Picture that. And so this is a good start point for our transpedicular approach. So make an incision. Don't just kind of drive it through there like I did. Picture.
Hey, Doug, can you describe the X-ray parameters of a perfectly orthogonal X-ray image for your target vertebral body so that the fellows can remember to reproduce that in the cadaver lab?
You bet. Steve's got it really lined up well. So we've got owl's eyes in the nose, and so equidistant with the pedicle, circular pedicle shadows in the upper half of the vertebral body. Smack dead midline is the spinous process with parallel end plates. And so this is what that looks like on the AP approach. And so I'm just going to start the transpedicular and perpendicular 10 o'clock and 2 o'clock approaches. Picture that. And then we're going to get toward the center of the pedicle like this. I want to kind of do an exercise. And one of the rules of thumb is never breach the medial wall of the pedicle before you're in the posterior portion of the vertebral body. So if we're nearing the medial wall of the pedicle like this, you can just turn this. This is the bevel needle, so keep your eye on the distal tip of the needle relative to the medial wall. Picture that. And it gives yourself 3 millimeters more. So we can drive it on in there, and let's take a lateral shot. And that's a transpedicular approach. I won't really belabor that much more because we've already seen that, and Neil went over that earlier with the diagram. And knowing that the pedicles are the waist of the hourglass shape, it's before you violate that medial wall, they're hourglass shaped, so you could actually violate a little bit, and we're past the posterior border, and so we're now in the vertebral body. You can kind of turn it around, medialize it a little bit if you want, and picture that and go on in. Let's come back around to AP. I want to show you a perpendicular approach. And depending on how hard the cement is, we'll go ahead and do a case of vertebral augmentation. Everybody, this is Taylor. She's here to help out. She makes us all look better. Thank God. So we are thankful that she's here. So let's give me a shot here. Picture. Picture. All right. So a line that goes from ipsilateral superior to contralateral inferior vertebral corner. Picture. Picture. Yeah, right there. We're going to take one vertebral body width out, and this is going to be our start point. And so I'm going to start at this point. That is the way that you measure this. It's according to the patient's body size. And so picture, I'm going to come down to the pedicle. And when you feel os, again, it's about, this is Ramos said, it's about 30 degree. So what we could do now is we can arc 15 degrees toward me, and we can make sure, because we want to put this perpendicular, so you want this to be just anterior to the pedicle. So we can confirm that using oblique and see the equator of the pedicle. See the tip is just anterior to the pedicle, right there at the equator of the 50-yard line. So we can go back AP. So shoot that again. And then, so we'll drive it on in there. And I'll just advance, same principle here. Picture. And before we violate the medial wall, let's go lateral. We want to make sure we're in the posterior portion of the vertebral body. And that is a perpendicular approach. And people get a little bit wrapped up in what is a perpendicular, what is a transpedicular approach. So perfect, right? And notice how similar these trajectories are, very similar. So, but this is not at 30 degrees. This is almost 45 degrees. I'm going to turn this around 180 degrees, put a little pressure on it. Picture that. And you can really medialize this. That's the power of the perpendicular approach, because you can gear shift this thing, rocker arm it, and you're not going through a pedicle, you're going around it so you won't break it off. Come back around AP and we'll probably see this at or close to the midline of the vertebral body. And this is the perpendicular approach. And that is absolutely nice right there. So that's the power of the perpendicular approach. You get to the center of the vertebral body very well. There's another approach. How are we doing on the cement? Good. So I'm going to show you the extrapedicular approach. Taylor, should we show them the extrapedicular approach?
Yeah.
Okay. Modified inferior in-plate extrapedicular approach. It's the approach with the longest name of all. So Steve, can you go 45 degrees toward you? And this is a kind of a wacky approach. This is something that we use to get around hardware, and this is typically an approach primarily used by neurosurgery for whatever reason. This is kind of tradition and inertia. Picture that. Picture that. So we're at 45 degrees, and I'm going to go just above the inferior end plate. I'm going to go just anterior to the pedicle, just below halfway up the vertebral body, because that's where the radicular artery sets. You can see the calcification of the aorta just to the right. The big blue and big red sit there, obviously. You can see the calcified aorta. The neural structures are more towards me, and below the radicular artery, which is halfway up the vertebral body, there's really nothing. There's a big swath of territory. Can you shoot that again? There's a big swath of territory with absolutely nothing there. And so typically, whenever you do this, a lot of times it's beneficial to use a coker, because in somebody that's not frozen, this is lateral to the multifidus, and this really flops around. Picture. And so I'm going to come up just a little bit superior there. Picture. And the entry point is going to be right there, just above the inferior end plate, just anterior to the pedicle. Picture that. And just below the 50-yard line on the vertebral body. So let's come back around to AP. And this is a very different approach, and typically we use this when there's problems with the pedicles, problems with the posterior access, trans or perpendicular, when there's big 6'5" pedicle screws in there. And so it's very different, and you can drive it in here, and we'll place it in the middle of the vertebral body, and we'll take a lateral view, please. And this will be in the middle or the anterior middle portion of the vertebral body. And this is called the modified inferior end plate extrapedicular approach. And so the needles I'm using are of the Merit system, and these have middle anterior, perfect. So let's come back around to AP, and I'm going to show a transpedicular approach with Arcadia balloon. So I'm actually going to work on a different vertebral body. And this is, picture here, picture, yep. So I'm going to do a transpedicular approach here, and with an access needle, and then I'm going to switch to the power curve. Just gotta like that name. So picture, and good transpedicular approach, and I'm going to picture. All right, let's see how we're doing. See if we're past that posterior wall yet. We have a few millimeters, about 5 millimeters before we get to that medial wall. So if we're a little bit short of the posterior wall on the lateral view, we'll just go back around AP and drive that sucker in. We're right at the posterior wall, so we'll just go ahead and drive it in a little bit, put 180 degrees, picture here. Don't want it to drift up, I want it to be more horizontal, so we'll make an angular correction there. We'll put it out here, and at this point in time, I'm going to take the stylet out, and we'll have the power curve. The needleology of the power curve, Taylor, come up here, so, is this goes toward the direction of this arrow. shocker, right? And this will dilate or circle dial this way. And as you dial rightward or clockwise, this comes up and will point the direction of the arrow approximately here. This is also beveled, so you have a tip and it exaggerates the steering capability. So this thing will really go. This has a lot of power to make the curve. And so we're going to try to get around to the contralateral side, coming out the tip. And so we'll come out the tip, picture, and I will start to put a little curve on it, picture that. You kind of see it foreshortening on itself, right? Picture. And here we go. And it's really foreshortening. It's coming back around. You can tell it's coming back around to face us, right? Mm-hmm. So now we'll go ahead and I'm going to take some tension off this picture. And we'll go ahead and come back around to AP, and this is going to create a channel for the Arcadia balloon. The Arcadia balloon's a very powerful, in terms of PSI rated, low compliance balloon. And so this is a nylon-based balloon, and you could get, it's rated, advance it just a smidge because we know it's going directly contralateral. Picture that. And that is pretty good right there. Shoot. Wonderful. And this is the bilateral results with a unilateral access is the tagline on this. So I'll just take the tension out, put that in. And the Arcadia balloon goes in the direction of the power curve, and righty-tighty, and this takes the curve, and it facilitates the curving of the balloon on the end. And so, all right, Taylor, step up here. Picture that. Okay, just barely outside, picture. And we're going to switch to lateral. And I want Taylor to put a half a turn on that and advance that balloon because we do have those two markers in there. I'll stand on either side of the II. Okay, let's see where we are. Oh, good. She's already advanced it a lot. That's a strong word. Fire, ready, aim principle. And so we're going to go ahead and put another turn on this, right? Go ahead and put about a whole turn. What you're going to see is you'll see the balloons and the marker bands foreshorten, come closer together. So just hold this stable and that turns. Yeah, okay. Shoot that, Steve. So it's starting to foreshorten those marker bands, and as she turns like this, she's going to advance by pressing in. Let me make sure that this is actually possible. Yeah, okay. So turn like this and advance that whole thing in. All right. See what we're dealing with there. Picture, Steve. Ooh, nice. So that looks very good. I mean, this is about as good as I think we can get. So I'm going to just push in just a smidge to have those marker bands line up perfectly. And then we're going to take it, we're going to trigger it, and we're going to make sure and start injecting through this Levine type syringe. We're start injecting contrast. So just take that righty-tighty on this one. It tells you the proximal end will tell you the pressures. So this upper portion is in PSI, and it also is a timer on this. And so this will, yeah, so we're at 52, 51 PSI. So go ahead and bring it on up and picture that, Steve. It says go ahead and crank on that. This balloon is very robust. It's tenacious. It does not break very easily. It can break, but it does not break very easily. And we're at the pressures of 300, and this is a different type of balloon. This is horizontally oriented. This is very medial lateral type of balloon. Keep going. And picture. Okay, stop right there. And so we'll take a look here. It's in the anterior one half of the vertebral body. Let's take a look at it on the AP. But the balloon looks round here, and the balloon is not round. It's oblong. It looks round here because we're seeing it directly on FOSS. And when we look at it from the side, we'll see that it's not round. And this is rated to about 700 PSI. Is that right, Jason? Yes. 700 PSI. And so it looks more like a thick sausage. So this is oblong, and now we'll just go ahead and we'll trigger that. So you just pull this and then pull back on it. Good, and pull back. And we're going to evacuate the contrast picture, and then keep on going. Yeah, it's going to suck it out, and we'll just gently pull on this, kind of facilitate that. Good. Picture. Great. So I'm going to take that whole thing out. And then after that, we're going to go ahead and put the cement in. So this is done through a curved needle. This has a fixed curve on the end of it to mimic the power curve. And I'm going to go ahead and get this started for you. Sometimes this is difficult to get in here unless you're used to putting things in, like the relievant cannula. Okay. So give me a shot there, Steve. Good. I'm going to back that cannula up a little bit. Picture, and let's flip back lateral, please. Let's go ahead and flip back lateral. And then this is the same pressure lead-in type syringe. And this is, we'll hydraulically inject the cement in here. The cement is located in this container, and this is hydraulic injection. It's very well controlled. So you have a good technical, tactile feel. You can see the curved needle entering, picture, entering the cavity right there, and I'll turn it back up. It's kind of drifting down, picture. And picture that.
Now, Doug, can you comment on what view you always use when putting cement into the vertebral body and why?
So we always fill in the lateral view. So as we say this, Taylor's just going to go ahead and make some turns. And the reason why is we're looking for extravasation. There's been some misnomers that go around that say, shoot, Steve, that say we're not supposed to fill to the posterior portion of the vertebral body. That is absolutely false and should not be repeated because it's just misinformation. You can fill to the posterior portion of the vertebral body. You just want to make sure that it doesn't extravasate. And the most common area of extravasation that will hurt people is through the basivertebral plexus. And as it comes back, it can get into, it can go through the anterior epidural ligaments, and it can extravasate into the spinal canal. It gives somebody a cauda equina or a spinal cord injury. That's what we fear the most. But let me give you some statistics. The last Pearl Diver database on extravasation that I saw was somewhere in the range of vertebroplasty was up to 70%. So extravasation is very, very common. Picture, yeah, perfect. And so we're just intermittent fluoro. You don't have to do this live. You can just do intermittent fluoro. And especially with this thick cement that's really well controlled. How does that feel?
Pretty tight.
Yeah, right. It's thick, right?
Yeah,
It's
really
very thick. So we're giving her some
nice.
carpal tunnel inducing activity. But see, it starts to integrate, interdigitate into the medullary bone within the vertebral body, and until it does that, you're not finished. When you just inject cement into the cavity, fills the balloon cavity, that will do really almost nothing to help. You have to get it interdigitating into the rest of the surrounding medullary or cancellous bone. So, and this is turning out really, really good, and we probably will not have enough cement for this one vertebral body just with this one kit. Jason has a nice Arcadia average volume of cement, and so once we get down to L4 and L5, we have 7.7 cc's and 8.17, and these are minimums, and this is to fill 18%. This is 18% of the fractures will be this. The minimum amount of cement that you want to fill,
It's kind of
you doing okay?
Yeah.
Is 15 to 25% of the non-compressed level is the minimum that you should be filling. Yeah, so we're out of cement here. That's good. And at this point in time, you could either stop, which is probably good. The goal is end plate to end plate between the pedicles. And so I'm going to go ahead and come out with this, and we'll take an AP view. But with the lumbar level, it's not unusual for me to fill 12, 13, 14 cc's in an L4. I mean, it's between the pedicles, end plate to end plate, and this is a fully non-compressed level at L4, so that looks very nice. Nice work.
It's Glenn.
Quick question: are you also doing that much in burst fractures as well? The amount of or a minimum amount
Of CCs in those areas.
So I'm not able to hear that question or comment.
It was a comment on burst fracture and volume. What routine volumes look like in the setting of burst fracture or fragmentation. is present?
No difference. So end plate to end plate, you want to get with a burst fracture. So burst fracture and trauma, let's differentiate that between, if Taylor drives your car on the interstate, goes into an embankment, and has a fracture that is a burst, that will be a high velocity fracture when young, healthy bone. If grandma falls from a standing height and has a fracture that's too wide and medial-lateral and too much of a length antero-posterior relative to the vertebral body above and below, that's also a burst, but we go ahead and treat it like an osteoporotic fracture. So there's really no difference in the required amount. It's still between the pedicles, end plate to end plate, but you need to be sure and get at least 15 to 25% of the non-compressed vertebral body volume at a minimum to be able to make sure and stabilize that. And the ante is even higher in a burst fracture because you need to have maximum stabilization of that fracture because that's the most unstable fracture that we have just of the vertebral body.
So how do you choose between transpedicular, extrapedicular, and parapedicular?
Just the goal I'm trying to accomplish and what I'm using. So if I want to go unilateral, I go parapedicular. If I'm doing a bilateral approach, a transpedicular approach is fine. If I want to get around hardware, if somebody's had prior surgery in the back, or I see fractures in the midst of spanning pedicle screws and rods all the time because it doesn't really work that well to stabilize the fracture. So in regard to what the final goal is, we'll tell you what your approach needs to be. And every year, for example, I use the modified inferior end plate extrapedicular approach about 10 to 15 times a year. So about once a month I need to use it. I'm not able to do all my fractures with one technique of those three. I have to have other techniques. And so if you have other techniques, then the whole panoply of vertebral fractures will be able to be treated by you.
How worried are you about the radicular artery during your inferior end plate?
So I didn't hear that. You cut out.
How worried do you get about anomalous radial artery coming around the vertebral body when you're doing your inferior end plate extrapedicular?
Yeah, so I care zero about that. And here's why. So if you hit the radicular artery, you can get bleeding. And sometimes if you hit the artery and it's just outside the bone, you take the stylet out, you can get pulsatile bleeding. I have hit the radicular artery, dozens of times, but it doesn't seem to ever give paraspinal hematoma. And the original paper, we did 96 patients, consecutive patients, and we did CT scans afterwards, physical examination afterwards. We compared them to see the outcome using this approach, some with a normal type of 10, 11 gauge needles, but some with larger access. I mean, some were very large in terms of diameter, but I've never knowingly had a problem with the radicular artery, even though I know that I have hit it on numerous occasions. I've never had a problem with a hematoma afterwards.
How concerned do you get about cement leak into the posterior vertebral body where the aorta lives? So
the cement into the paraspinal anterior is unimportant. So I had a colleague of mine said, as somebody with a couple of flecks of cement into the lungs. So extravasation into the veins that's important because you don't want to have pulmonary emboli. And so, he said, I've got a couple of pulmonary emboli, what should I do? And my answer was nothing. My answer was panic. And then I got him worried. Then I said, no, it's nothing, because in the Vertas 2 trial is the best example of how often that pulmonary emboli happened. It happened 26% of the time, and as it was evaluated by post-op CT. So this is more common than the incidence of blue eyes in the United States. So if you do vertebral augmentation, you will get PE about 26% of the time statistically. So the extravasation posteriorly along the basivertebral plexus, it is constrained by the ligament of Trollard and the anterior epidural ligaments. It has a very characteristic appearance. And my theory is God made the anterior epidural ligaments to constrain the extravasation into the basivertebral plexus, and it looks lenticular. It looks like a very lenticular convex lens, and then it'll fill, and it'll fill, and it'll fill, and then it will shoot up and down. So the cement can actually be constrained by these ligaments, and your job is just to recognize that that's happening. Stop, let the cement harden, because it hardens in the body a lot faster than on the back table, and then keep going after it's hard.
And there was a safety evaluation in the vertebral compression fracture registry, that's 700 plus patients, for frequency of neurologic deficit associated with the procedure, which would routinely be explained by cement leaking into the neuroforamen or cement leaking where the neurologic structures were. And the incidence in 735 patients was 0.
0.
So cement leakage occurs in a quarter or more of the procedures, depending upon which kind of procedure you do, a kyphoplasty or vertebroplasty. Cement leakage is very frequent. Adverse events associated with it are nearly 0. So what the cement leakage is telling you about is the characteristic of the fracture. So you'll see in metastases to the spine that the characteristic is not to contain the cement because the bone has been eroded and is very porous from the tumor. So when you're looking at fractures, they also have characteristics. So if you see a cement leak, it just tells you pay close attention to the column where the spinal nerves, the dural sac is. If there's no threat to the dural sac, there is no concern for the patient.
Okay.
One more.
Yes.
Do you routinely re-image after
So I didn't hear that question.
Re-imaging after kyphoplasty, either in the acute setting or in the follow-up setting?
Yeah, no, nobody does it routinely. You can get CTs. I do CTs after, try to do after all of mine, but that's just to check the civil engineering of the spine, but it is not required, nor is it common.
Great. Thanks, Doug.
Thanks, guys.
Ben, can you tee up my talk? Or do I just need to click something up here I don't recognize?